The problem, I think, with education sometimes, especially medical education, is we want to separate the anatomy and we want to separate the pathophysiology and we want to separate the pharmacology and the treatment. And I just don't know if our goal is the person and treating the condition, then they all have to happen together. And, that's not, my brain doesn't work in silos. And the more I make my brain work in silos, the more it will be siloed. So constantly presenting it from the perspective of what does this mean for this patient? Because the pathology is irrelevant. Your ability to score, 100% on a test about epidural hemorrhage is irrelevant. It's your application to the person. So what I need to know is, do you know it well enough that you know why you perform the care you perform?
So let's say you have a head injury.
Yeah.
What's the patho going on with a head injury patient's blunt trauma, baseball bat to the head, we'll say.
Yeah. And you know
How
what?
would
I think that's the perfect place to start because that's how I'd start it. Is, to say we've got a, patient who's been ejected from a vehicle or who's taken a baseball bat to the head, fallen from height, and has significant head trauma, and we'd work through differential diagnosis. So you basically just prime people. This works with PCP, ACP, and you ask them what are the types of things that could be going on. So what is our big differential, and then we can start to narrow it down. And again, this is where you probably start to foster that trust. I don't care if you have the wrong answer. I'll write it down. So whatever you say, I'm writing on the board. Let's get a big differential diagnosis. So, someone might say they could be having an embolic stroke. That's 100% wrong. But whatever, let's put it on the differential. And then now what we can do, we can start to prioritize what is likely to be wrong with that person. So wrong answers are just as good as right answers when you're thinking about something like a differential diagnosis, because you can then put them in order. And those are the things that matter. So again, I don't care often so much to the rote pieces of it to say, this is this or this is that. If you're looking at someone who's been struck in the head, let's talk about all the things it could be. And now let's talk about what's most likely. And now we're already doing some critical thinking. So by saying what I would do in that instance is say, okay, we got a list of 30 things now. I want you to list them 1 to 5 in most likely to least likely order and say why. So now the person already has to start making that next step in terms of critical thinking as to what one has to be more right than the other. And what I like about that is people go, well, it could be two things. It could be an epidural bleed and it could be a subdural bleed. Sure. I don't care. I want you to pick which one you think is more likely and why. No, we can't do imaging. We have no idea, but forcing them to rationalize starts to make them think of what they have to do or why they're going to get there.
So let's start from the top then. You'd build a case study because it applies to paramedic practice and it gives you context
Yeah.
to what you're trying to learn instead of just saying on the board, oh, here's an epidural hematoma.
Exactly. Yeah. Almost always start with a case. With the ACPs, I like it even better because then I ask the people and say, you guys were out there. Give me a case where you thought someone had an epidural or subdural hematoma. So they set the scene. And what I like about case study building is often, I want to know, where am I? What's around me? What does it smell like? What's it look like? People often laugh because I give like super vivid imagery of the person. Again, for PCPs, if I've never seen a patient, I'm going to try to build a patient as much as possible for you so that your first repetition on the road, at least you have something close that you can pull from instead of never seeing it. So, case study, I will always advocate for the use of case studies or at least very descriptive cases to start off any type of education.
And you said such a key point too, like for the ACPs, like I'm trying to grab from your experience because that's part of adult learning. It's like you're an adult learner. You have tons of experience, and the best that you learn is connecting it through your world experience.
Yeah. Exactly. Yeah, exactly. And people engage. Like when someone, medics and medical professionals in general, I think are interesting like that is people like to hear stories from the road. You know, someone tells a story from the road at base, as long as you haven't heard it 700 times. Usually you're interested to hear about those because context matters. Cases are so different every time.
I love that you get into the nitty-gritty details of the smells, the scenes
Yeah.
to give it that very cerebral context saying like, "Oh, I can picture that." Like it's
Yeah.
resonating with me, so I'm more engaged and more willing to learn. Then I love that you did with the differentials because that hits a lot of Bloom's taxonomy. And if people don't know what that is, it's this very nebulous kind of triangle, but it helps the learner to apply,
Yeah.
comprehend, understand, right? And just pick the best differential based on all these levels of learning and comprehending and applying you're doing.
Yeah. Yeah, 100%. At the end of the day, it's the critical thinking and the creative thinking around medicine that is the key. Like the rote memorization or simply understanding a piece of pathology is irrelevant. And that's usually where I go with the pathology is I'll explain it all. Like we will go through the pathology from the start. So say we're talking head injury, from the rupture of your middle meningeal artery all the way to mass effect and brain herniation. A lot of it is less relevant, but where I think the pathophysiology is always important is that is what drives my care. So if I know why, Mass Effect and cerebral herniation is a bad thing, then I know and why it's happening, then I can appreciate why the treatment is important. If I can know why the person is likely to seize with, massive cerebral hemorrhage, then I can appreciate what might or might not work in terms of treatment. So, I think it's dangerous to say that the directives don't matter and I don't need to know the directive specifically to know how to treat the patient. But if I've done my job correctly and I explain and people understand why someone presents the way they do and what would be beneficial for them, then you know why the directive is written the way it is because the directive is based on the pathology and what to do for the pathology.
So you take this abstract patho example and you give it context and meaning and you apply it to the treatments to overall enhance patient safety.
Yeah. Yeah, and that's exactly it. And that's what I like is the problem I think with education sometimes, especially medical education, is we want to separate the anatomy and we want to separate the pathophysiology and we want to separate the pharmacology and the treatment. And I just don't know if our goal is the person and treating the condition, then they all have to happen together. And, that's not my brain doesn't work in silos. And the more I make my brain work in silos, the more it will be siloed. So constantly presenting it from the perspective of what does this mean for this patient? Because the pathology is irrelevant. Your ability to score, 100% on a test about epidural hemorrhage is irrelevant. It's your application to the person. So what I need to know is, do you know it well enough that you know why you perform the care you perform?
So let's say patient, blown middle cerebral artery, posturing, cerebral posturing, blown pupils, they got Cheyne-Stokes respirations. What's the treatment for that and why?
So, I mean, depends on what level you're looking at, but automatically we got to go BLS care. So, it, you know, which arteries is relevant, but I've got massive cerebral hemorrhage. I'm showing signs of increased ICP. And this is where it matters, right? So I'm bleeding in my brain, and I know that that bleeding is causing a number of different things. Everyone loves to talk about the ICP pathway. So I got increasing ICP, which means my cerebral perfusion pressure goes down, which means that my body will respond. So it's going to compensate by increasing my mean arterial blood pressure, which is just going to make bleeding worse. And that's a great cycle to know. It is almost irrelevant to why I'm performing my care. Um, so that's what I need to know. So usually when people talk about increasing ICP and cerebral hemorrhage, that's all they focus on. They don't consider the fact that the patient's got cerebral ischemia. So the blood's not getting to the brain. I got cerebral ischemia. I've got mass effect or large amount of mass growing in a confined space that is just shoving my brain through my foramen magnum, which is compressing my brain stem. My cells are dying. So I'm releasing glutamate. I'm reducing my seizure threshold. So I'm at much more higher risk of seizure. I'm compressing my medulla. So my respiratory status starts to go down. And I may be not breathing well enough. Maybe I'm not breathing at all. So I'm hypoxic. So if you think about those things together, I've got low flow to the brain. So I've got pressure, which is pushing on vessels and not allowing for flow, and the blood's not getting to where it needs to. So I get a low flow state, brain's hypoxic. I've got release of glutamate, I've got inflammation, I've got physical compression, seizure threshold is low. And I've got someone who is not able to compensate well. I'm legitimately crushing the structures that would allow for effective compensation. And I think maybe sometimes the nice thing about our bodies is once we get really sick, it just tries to push us closer to death as fast as possible. I have compensatory mechanisms that are actually bad for me. So I'm increasing mean arterial blood pressure, potentially increasing mean arterial blood pressure, which is shoving more blood in my brain. So hypoxia, more blood in my brain, low seizure threshold. So if I can think about those things, I could probably, even a layperson, you could probably say, well, what would you do to manage that? If I'm hypoxic, I need to manage the hypoxia. We know the patient's not breathing well, so those two things go hand in hand. So the key would be good established airway control. So I need to ventilate well for you. OPA, BVM, two-handed seal. And this, the problem is it's easy for us to check that box. Is like, yeah, I ventilated the patient. It's like, well, wait a second. What did we say were the critical pieces that were important for this person? We said hypoxia is one of the big problems here. I'm not getting enough oxygen to the brain. That's causing reduced cerebral perfusion and it's causing some of these compensatory mechanisms. So it's not just, well, I put an OPA in and I ventilated them. Did I do a good job? And am I managing the metrics I need to metric? Did I actually look at my oxygen saturation and see if I was making a difference? Did I put my end-tidal CO2 on and see, do I have a good seal? Do I have any leaking around the mask? Have I actually positioned the patient in the way that the best way possible? Because if that was one of the things I listed as number one important, then why am I doing anything else before I really establish that as key? Nice thing about that too is we know that increasing blood is a problem, and I want to reduce the amount of blood getting into the brain. So now I can use my end-tidal and target my ATCO2 at 30 to 35. So I can manage my respiratory rate, I can manage my oxygen saturation, I can manage my end-tidal CO2, and I've got a machine that will legitimately give me all of those metrics in real time if I just look for them and I decide that that's important to me. And I think that is part of it. We've talked to Orange recently on this podcast. They talk about resuscitation before transport. Yes, transport matters. Yes, getting the person off scene is important, but not at the detriment of the things that will actually slow the pathological progression. So what I think sometimes the challenge is if I teach that patho in a patho class and that's it, I just put that in a single flow chart and I don't address care, is it's easy for me to say, okay, what's important here is increasing an MABP. It's not, it's the effect. It's what the problem is. So I think it's so important to kind of outline the pathology and then the impact on the patient and then make them think about care, not just from a, what do you do, but what do you have to do well perspective, is so important. Raising the stretcher 30 degrees. A lot of people come up with that on their own because you'll talk about, there's too much blood going to the brain. What would be an easy way to fix that? And they're like, gravity would help. Yeah. Well, maybe. We don't know. There's more evidence coming out about this. But right now, 30-degree positioning makes physiological sense and has some evidence to support it for the patient. So you're going to reduce some of that blood flow to the brain. Often we'll talk about seizure thresholds with the ACPs. So, the destruction of those cells, think about what's causing the seizure. This is not an epileptic. This is not someone who is, seizing because they've got increased automaticity in their hippocampus at their temporal lobe. This is someone who's seizing because their brain is being ripped apart and their cells are dumping their excitatory neurotransmitters into the other ones, and I'm pushing on it with blood. That's a much harder seizure to manage than an epileptic seizure. So I need to think about that in terms of my care. And then again, you can take that so easily into, well, what would be the consequence? The patient has a low seizure threshold. Will they seize? Well, do we really care what's the problem with the seizure? Well, they're not breathing and they're demanding more oxygen. What was the number one problem? We've got poor oxygen to the brain. So it's making people and almost forcing them to make those connections. And I've been asking the question and answering my own question here. That's how I do it, is I'd ask the question and I would force an answer because everyone can come up with it. Any PCP, ACP, by the time we get to these types of discussions, they've been immersed enough that they can come up with it. They just have to feel comfortable saying what they think it is. So It's that type of engagement. So I think you have to shove it all together and be iterative. So a lot of times we try to make sure that every course is considering the patient. What is the impact on the patient, and what does it matter for the patient in order to actually care for them? The other piece that's harder, I think, sometimes is then including the evidence. So, if we're talking about head injury, you then have to do a lot of kind of cognitive gymnastics to say, I think it'd be easy argument. Usually I'd ask people, would intubation be beneficial for this person? And a lot of people go, well, you just said hypoxia is the problem. Airway management can be a concern. Patients at risk of seizure, intubation would definitively manage your airway. And that's where you have to kind of outline what a perfect world looks like versus the world we live in and start bringing that evidence in. Is that absolutely first pass success in intubation would be beneficial for that patient. But if I miss that tube 7 times, probably not the best. So you have to start thinking about those types of things and having a real strong evidence-based discussion. But how do you do that until you've really fleshed out what's wrong? What do they need? What am I going to do for them? And then we can start talking about well, how good am I at doing the things that I'm doing? And that's often a question I have a lot. And I think that is probably unique sometimes is people don't think about that. They're like, of course I'm good at it. I'm like, are you? Let's see if we actually are.
And that's a missing piece that you add in. And this is the nebulous piece of research. Like vast majority of people don't really care to read research articles. Like a small minority do. But how do you take that we are trying to adhere to best practice guidelines, the highest empirical evidence, but make it digestible for paramedics and students?
That's a great question. I honestly, I don't know that I've really mastered that piece of it. What I try to do is talk about significant impacts. So, when you've read it a whole bunch of times, you know this. You start to know the stats. So you know the stats, and that will make me look smart, but has nothing to do with them. So I find myself more and more trying to phrase these types of things in terms of quality of evidence. So this is important because we have robust, high quality evidence to support it. So I can't use as much as I might like doing something. I got to use if evidence matters, it matters. So I'll often talk about the quality of evidence, and I don't often get into why. So sometimes they'll ask, but if I'm time limited, I just want them to know this is high quality evidence. And then I often will talk about significant impacts on morbidity and mortality. And something I took away from our conversation with Dr. Lori Morrison is what does that mean for the person? So this is not just oh, they have reduced mortality or morbidity or increased morbidity and mortality. What does that actually mean from outcome? And that's been a question I've loved integrating into the course is, okay, you fail your intubation attempt 3 times and you get it on the fourth on, dude who's been hit in the head with the baseball bat and is posturing on your stretcher. What does that mean for him 3 months from now if he survives? And that I find really resonates with people when you start talking about things like rank and score and what good neurological outcome means at discharge. Um, you create that dissonance. I always tell people, remember, if you're going to do the thing that is against the evidence, you just remember this conversation and me saying, that's um, as we're doing the wrong thing that we know. We just talked about how high quality evidence it is, and we just talked about the tangible human impact. How do I make the alternative decision sometimes?
The humanized experience that you spoke about, they may never do up their pajamas on their own again. You
Right.
have to remember that.
Yeah. You look at trauma being the biggest impact on young people. So, like, cause of death or cause of morbidity and mortality in young people. Think about what that means. Like when I've got that 18-year-old head injury, that I could either manage really good BLS because I don't think I can intubate them, and I think I can manage their airway really well. And I don't want to make that first attempt because I'm almost positive I'm going to miss it, regardless of the circumstances. So I can make that decision, or I could make 2 really shitty intubation attempts and miss both times knowing that I was gonna miss probably the first time. Um, and then walk away saying that person's not going to be able to complete their education to, interact with their family in a way that they would find meaningful. That I think is important to recognize.
Last question before you, so I let you go to your family. At the end of your career, what would be the threshold for you to say that was successful? Like me teaching was successful. What's the benchmark?
I think I think there's 2 things. If I ever become stagnant, I hope someone lets me know. If I'm doing the same thing over and over again because it's easy, then I need to quit. And I need to do something else. I'll go be a paper pusher in an administrative job. Um, so and I think that's a piece of it, is I think that if I lose what is necessary, whether that's motivation or ability or whatever it is, relevance maybe, like even like maybe, I don't know, I become so outdated that I refuse to keep up with the times. I think a successful career will be knowing when to quit, and to let someone else do it. And I think that is the other piece for me is I hope that just like I've had multiple people help me get to where I am today, and I think, start to excel as an educator. That's what I want is just as much as I love educating the next generation of paramedics, I hope I can educate the next generation of paramedic educators. It shouldn't be about me. Whenever I make content or I make a course, I always think about who's gonna do this next, and what can I do to set them up for success. So I know I'd love to leave this career with wherever it is, with a program or an educational program that I've helped establish a lot of people in their roles, and they're probably doing it 10 times better than me.
Those are amazing pursuits. You're doing incredible work, and I know people will appreciate those.
Thanks. Thanks. This was fun.